Welcome to the American Academy of Emergency Medicine's Justice, Equity, Diversity, and Inclusion sections presentation. This is the fourth installment of our mentorship webinar series. Tonight's topic is addiction in the emergency department, sickness, stereotyping, and stigma. My name is Kristin Fontes. My pronouns are she, her. I am a board certified emergency medicine physician working in the community, and I will be your speaker tonight. This session is meant to be interactive, and while I'm here to teach, I love learning from others. It actually makes me a better teacher, but I also want to just be very transparent and say that even though I have an experience with health disparities that affect the communities that I belong to, I'm constantly having to educate myself about health issues that affect other groups, especially other racial groups, and unlearn some of the things that I was taught previously, like in medical school and residency. It's a long-term process, and I'm certainly not an expert, so I do want to hear from you. We do have plenty of time for questions and comments. I'm not going to speak for the entire hour today, so feel free to speak up at any time. If you have anything you want to ask or share, go ahead and raise your hand, unmute yourself, use the chat function, whatever works for you. I am sort of doing like solo operations here, so if I don't happen to see your hand raised or anything like that, just shoot a note into the chat. I will do my best to keep track of any activity that's going on there. Also, I should also just mention that I am actually at a conference this week, so I'm doing this from my hotel room. Hopefully there won't be any internet issues, but if there is any like glaring issue with the audio or anything like that, just throw something in the chat so I can be aware of that. Thank you very much. All right, I am going to go ahead and share my screen now. Okay. All right, get my notes here too. So this session is dedicated to addiction in the emergency department and how bias and discrimination can affect the care of patients with substance use disorders. I really appreciate everyone being here, whether you're in attendance now or watching this later. But before we start, I think it's important to acknowledge that this session, while it is meant to be educational and in the interest of health equity, does include content about the social stigmatization of addiction and the intersectional oppression that is faced by people of color and unhoused people, and that may be triggering. So if at any point you need to step away to take care of yourself, please do so. Your well-being is important to us. And before we move forward, I just want to take a moment and say a huge thanks to Kara Gardner for putting the majority of the slides together that you'll see tonight. So Kara has been very involved with our AAEM JEDI section. She's been instrumental in reaching out to medical students, especially those who are underrepresented in medicine. So thank you very much, Kara, for your work and your outreach. All right, so first, I think one of the issues that we need to address is the complex role that stigma plays in substance use disorders. Okay, I think it's important that we view stigma just like any other form of social oppression. So for example, consider the multiple forms of racism under the systemic racism umbrella. We have institutional racism through which policy creates oppression for people of color. There's interpersonal racism through which individuals in a position of power, it should be noted, discriminate against people of color. And then there's internalized racism, which mostly refers to an internal acceptance of racial inferiority. Now let's look at addiction. This is a social construct when you really think about it, just like race. With stigma, we have the public stigmatization in which we learn to view people with substance abuse or substance use disorders negatively. We stereotype them as being associated with crime, violence, and being a bad influence on others. Now, this social learning has multiple roots. This is before my time and probably before a lot of the folks in here's time, but the war on drugs back from the 1970s after President Nixon declared drug use public enemy #1. Think of the message that sent to the general population, especially those struggling with addiction. Think about mandatory minimum sentencing for even minor drug offenses. That sends a message. Even the portrayal of substance use disorders on TV and in the movies. I would actually consider even reality TV. Like I came across a paper that was written specifically about the TV show Intervention, which I used to watch all the time. But in looking through this paper, this author was really compelling in noting that not only were the majority, like almost 90% of the people on that TV show that had a substance use problem were white people, but that the show, through what it portrayed and what it showed us, actually kind of includes this narrative that sort of operationalizes whiteness. When you consider that the outcome, or at least the goal in each episode, was to sort of, in a very kind way, in a very accessible way, offer treatment to people with substance use disorders. But what we know is that if we look at, criminal justice, for example, people of color, and I'm including Indigenous, Latinx, Black people, are way more likely to be booked into jail and receive harsher sentences for the same drug and alcohol related offenses as white people. So our perception of addiction, substance use, treatment, all of that is definitely influenced by a lot of these things we experience in our lifetime, but also in popular culture and media. So that's the public stigmatization. Okay, we also have folks who respond to the public stigma with this sense of righteous indignation. So, for example, I think of this when I think of areas in the country where health policy denies folks with opioid use disorder free access to naloxone for overdose. And this policy is often accompanied by messaging that providing the antidote will actually somehow encourage more dangerous and criminal behavior. Think about how that must impact someone struggling with opioid use. The idea that the outcome of death from an opioid overdose is preferred over some hypothetical scenario in which the life-saving treatment gets abused. So that absolutely compounds the stigma. And then there is this internalized or self-stigmatization, in which all these negative stereotypes and the social criticism create an internal sense of inferiority and shame that gets normalized. I use the term shame specifically to describe the condition in which a person harbors a negative view of their whole selves, which is in contrast to guilt, which more refers to the culpability felt because of an action they took. So they start to think of themselves as bad and unworthy. They don't just feel bad for using, they feel, they have very low self-esteem as a result of this problem. So you can see how hard it would be for someone in this position to successfully recover. As we can see illustrated by this person's words here on the slide, we push people with substance use disorders to the margins of society. And they also feel as though they belong there, that there's little hope for them to recover, and to sort of regain their self-esteem and their self-love. It is a double-edged sword. So what this person said is that, there's a time in my life where I'd be paranoid about sitting around other people's possessions, because if anything went missing, generally 9 out of 10 people in the room would be dismissed and I'd get the blame. There's a lot of discomfort within yourself after coming out of that lifestyle, referring to having a substance use disorder. So how do substance use disorders develop? You might have seen this graphic before. It's the relationship between stress and performance. So on the left-hand side, we see that when we're under little or no pressure, our morale tends to be low and we aren't really motivated to get much done. This is sometimes referred to as bore out. As we start to experience stress and kind of move towards the center of the horizontal axis, it makes us more alert. We experience stress, we get more alert, we get more interested in performing. And there's that sweet spot right in the middle of this curve where we experience just the right amount of stress to achieve peak performance. And then as we move even farther to the right, when we see there is too much stress, we start to become anxious. Our performance starts to decline, and eventually we burn out when stress is maximal. So how does this apply to the development of substance use disorders? Well, consider what happens when we're exposed to repeated stress over a period of time. This is known as allostatic load. And this is defined officially as the cost of chronic exposure to elevated or fluctuating endocrine or neural responses resulting from chronic or repeated challenges that the individual experiences as stressful. So just one right after another, creating sort of this altered set point, as you can see, for homeostasis. There are 4 different situations that can lead to the development of allostatic load, and I have them listed over on the left side of the slide. So there is exposure to frequent stressors and repeated psychological effects that come with them, the lack of adaptation to repeated stressors, an inability to shut off the stress response following a stressful event, and an insufficient response to be able to cope with the stressor. So you can imagine that someone struggling with a substance use disorder is already experiencing stress repeatedly for multiple reasons related to their addiction. But there also appears to be a link between things like adverse childhood experiences, known as ACEs, in that there is a higher prevalence of ACEs among people with substance use disorders when compared to the general population. And ACEs may also influence the severity of a substance use disorder. So the allostatic load likely begins in childhood for many of these people. It's not something that just sort of like flips on at any moment during adulthood. Now, allostatic load absolutely has the capacity to alter brain function. What we think happens due to the effects of stress hormones, like, for example, cortisol, corticotropin releasing factor, the hippocampus, which is responsible for learning and memory, and our prefrontal cortex, which handles our impulse control, those 2 functions get weaker. And the amygdala, which is responsible for our emotions, gets stronger. So when someone is struggling with addiction, the brain goes into this state where there is a loss of control, there is negative emotions, and there's craving. All right. Here we have some data from a survey of patients with substance use disorders in New York City. These questions that are shown here relate specifically to the feeling of alienation. As you can see, the majority of respondents report avoiding people because of the perception of being looked down upon because of their substance use, that they feel they have to go the extra mile to prove themselves because of their drug use, and they feel ashamed simply because they use. All right, so there is a lot to really unpack here when we're talking about the self-stigmatization. So that's why I wanted to really make sure I mentioned this particular data set. Now, despite the well-documented medical and mental health effects, substance use is often viewed as a moral shortcoming. This is some data from a public opinion survey from 2014 that compared attitudes about mental health and substance use. And what they found was that respondents were more likely to accept discriminatory practices against people with substance use disorders. They were more likely to be skeptical about treatment effectiveness, and they were more likely to oppose public policy intended to help people with substance use disorders. In contrast, respondents were more likely to hold supportive and less discriminatory views toward people with mental health issues. The element, this element in particular of stigma can and does lead to discrimination. Here's what that might translate to into real life. And this is listed on the slide here. As you can see, more than half of the respondents in this survey believe that landlords should be able to deny housing to a person with a substance use disorder, whereas only 15% of respondents felt that way about a person with a mental health disorder. Similarly, less than 1/4 of respondents felt the government should subsidize housing for a person with a substance use disorder, but more than half of respondents felt that it was appropriate for a person with a mental health disorder. Although substance use disorders are considered a mental health issue, medically speaking, the average person, clearly based on this study, will see them as mutually exclusive or has the capacity to. Alcohol and drug use themselves are significantly linked to housing stability. People who are unhoused have a higher prevalence and severity of substance use disorders. A study of ED patients from 2018 in an urban area found that nearly 45% of unhoused patients reported a history of at least one opioid overdose at some point in their lives. 45%, that's a huge proportion of people. And as you can see here, the #1 cause of death in a person experiencing homelessness is drug overdose. One interesting thing that the authors of that 2018 study brought up was that despite the overlap between being unhoused and having a substance use disorder, it doesn't appear that much attention has been paid to housing status when people undergo what's known as ED-based SBIRT programs. Now, SBIRT is an acronym that stands for Screening, Brief Intervention, and Referral to Treatment. This is a government program that is often used to assist patients with substance use disorders. So not addressing housing in this intervention represents a huge gap in the care that we provide to these patients who might otherwise really benefit from interventions that address both simultaneously. Oh, sorry, one second, I lost my notes. Okay. In addition to the baseline difficulty these patients have, like physically with craving and withdrawal symptoms, seeking medical care can actually be risky. What's important to understand about stereotyping is that it's dependent on the culture of the group that's creating those generalizations. Unfortunately, despite being the providers of treatment for substance use disorders, healthcare professionals often harbor negative stereotypes about those patients. According to a systematic review of 28 studies, healthcare providers tended to view patients with substance use disorders as violent, manipulative, and poorly motivated to get better. This review also found that healthcare providers also lacked adequate education and training in caring for these patients. And given that in an acute care setting like the ED, we're pretty task-oriented people, like we just need to get things done to keep things moving. We often also just miss the mark when it comes to empathy and trying to really understand these patients. So that's what I mean when I say our culture determines our stereotypes. Like we are sort of taught in this way. We're not necessarily always supported to be able to like sit down and have a meaningful discussion and really try to help these patients in a way that works for them. As a physician, I have certainly found myself in that position before. You know, classic example that I can think of is how we treat people with alcohol use disorder who present with concerns for withdrawal. You know, maybe they have some clinical signs of withdrawal, but maybe it's not so severe that they need to be admitted to the hospital right then and there. So we give them some oral benzodiazepines to treat the withdrawal symptoms. And then what do we do when they feel better? We discharge them, or at least I certainly have, we discharge them without medication out of fear that the patient will combine benzos and alcohol to intensify their level of intoxication. We've learned not to trust them. And ultimately, we help them believe that they don't deserve to get better. They may actually use to reduce the feeling of shame that they experience because of an interaction that we have with them. And this is what's known as the looping effect, where the negative stereotype feeds back into the behavior that then begets more negative stereotyping. So it is absolutely a vicious cycle. But beyond how we treat individual patients, think about how our generalizations may affect groups of patients. As physicians in particular, we have a big platform and we occupy a powerful place in society. So how we behave goes a long way and it reaches a lot of people, especially when we're like featured on the news and we have lots of followers on social media. Despite our intentions to cure illness and preserve life, the impact that our actions have, they have the capacity to negatively affect many people. I've heard patients describe how difficult it was for them to even make the decision to seek treatment for substance use because of fear of being mistreated or discriminated against by a healthcare provider. If you've ever listened to the MRAP podcast or heard Mel Herbert speak in any way, you've probably heard him say, "What you do matters." He says it all the time. And while I try to remember those words in a positive sense, like during the worst clinical shifts, like don't forget what you do matters, this matters, I think it's also important to consider these words in the context of the negative impacts that sometimes our words and actions have on patients. So when we don't treat patients with substance use disorders equitably and with dignity and respect, that matters too. Okay. We really need to do better in this area. We know that these patients need comprehensive care and services. It is the right thing to do morally, but also initiating treatment in the emergency department is not only feasible, it's effective. So here is a randomized clinical trial that was published in JAMA in 2015 that compared 3 different intervention strategies for opioid dependent patients in the emergency department. So participants were randomized to one of 3 groups: screening and referral to treatment, SBIRT, which is the brief intervention that I mentioned before, and then a combination of screening, brief intervention, and an ED-initiated treatment with buprenorphine/naloxone and referral to primary care for a 10-week follow-up. So just for clarity, the brief intervention that I keep referring to in this study was a 10 to 15-minute interview in which the researcher did 4 things with the patient. They raised the subject, provided feedback, enhanced motivation, and then negotiated and advised. So there was a very personalized component to that brief intervention. The primary outcome of the study was whether patients enrolled in and received substance use treatment 30 days after their ED intervention. They also looked at a few secondary outcomes, including self-reported days of illicit opioid use after the ED intervention. Now, when it came to engagement in addiction treatment at 30 days, the buprenorphine group had the greatest success, so 78% of those patients versus 37% in the referral group, so people that just got resources handed to them, and then 45% in the brief intervention group, 45%. So a much larger percentage of people that received medication and scheduled follow-up had greater success. And these were all statistically significant findings. In terms of illicit opioid use, as you can see listed here, the buprenorphine group had the greatest reduction in use relative to the other intervention groups, but all 3 groups had statistically significant reduction in illicit opioid use. And the effect between groups was also statistically significant. Interestingly, the authors of this study brought up the idea that while SBIRT programs aren't like officially recommended because there's some evidence that's lacking to sort of formally recommend them from a federal standpoint, the study here found that referrals were actually pretty successful in the 2 groups that didn't receive buprenorphine. But the researchers went a bit outside the usual SBIRT model and offered referrals to community services that accepted the patient's insurance, which we know is a barrier for a lot of people, in addition to facilitated referrals with psychosocial intervention, both of which may have actually increased the patient's chances of getting treatment at the time of the 30-day follow-up. I really appreciate that the authors of this study brought that up because it's a great example of how meeting patients where they are can and does translate into more equitable healthcare. So here is a proposed intervention strategy for the emergency department that incorporates multiple treatment elements, except for the brief intervention interview that I mentioned in the last study. So we start with, at the top, identifying whether the patient is in active opioid withdrawal. If withdrawal symptoms are present and the other conditions are appropriate, we can immediately start medication-assisted therapy, or MAT, as long as the patient is not on chronic opioids and they aren't receiving an opioid prescription during that visit. Let's say the patient's not in opioid withdrawal, though. It's a little bit more challenging. How do we identify patients with opioid use disorder? Let's just talk for a moment about targeted screening, which is what they put on this little flow diagram here. This could be a challenge in the ED. We have to be thorough, but brief. And the screening tool needs to be compatible with our workflow, which, like, for anyone here that works in the ED, like, it can be like kind of all over the place and chaotic rather than a workflow. Most of the available screening tools that are out there have been validated, but not necessarily studied in the ED setting. There is one tool called the Revised Screener and Opioid Assessment for Patients with Pain, also known as SOAP-R, that was developed in the outpatient setting for chronic pain patients, but has been studied in the ED environment and takes most patients about 5 minutes or less to complete. It's 24 questions. Additionally, the World Health Organization and National Institute on Drug Abuse have also developed and validated their own tools, which are both versions of the alcohol, smoking, and substance involvement screening test. Now, those have limited data on use in the ED, but it does appear to be helpful, at least in identifying patients with non-medical prescription opioid use. Now, under the sort of screening box there to identify patients with opioid use disorders, using screening in conjunction with prescription drug monitoring programs where you go online and pull up an individual patient's history of filling controlled substance prescriptions. But using a prescription database as a standalone is not likely adequate for screening. So there needs to be something else used with it. And like I said, there are tools out there. Some of them have been studying the ED, most of them have not. Okay, so Looking down a little bit further on the algorithm here, regardless of whether the patient is interested in initiating medication-assisted therapy, we should always at least offer outpatient resources. And as we've seen, we should ideally be offering services that the patient can actually access physically, financially, et cetera. This is where case managers and social workers can really play an important role in helping patients get treatment that they can actually follow through with. These days, many institutions have continuity of care programs in place for these patients. So once they are discharged from the ED, they are closely connected to ongoing treatment resources. So for example, where I work in Southern California, our county public health department opened a bridge clinic for patients to either initiate or continue their MAT treatment. Once that was established, our emergency department physicians then went through the process of getting X waivers that allow us to prescribe buprenorphine naloxone so that the patients will have medication between the time they leave the ED and the time that they arrive at the bridge clinic. And as you can see at the very bottom of this figure, the linkage to outpatient care, while it is the last step and happens after the patient is clinically stable, is a really crucial step. As we saw previously, patients who receive both medication and facilitated follow-up are more likely to be receiving treatment in the weeks that follow after their ED visit. So our approach really needs to be comprehensive here and very intentional. Okay, as we reach the end of our discussion, I just wanted to go through a quick hypothetical case. So let's say you're working in the emergency department and EMS brings in a patient who's unconscious and they have respiratory depression. Say the patient's about 50 years old, they're a Black person, and they appear disheveled. Paramedics tell you that they picked up the patient at a nearby street corner when a bystander saw them lying on the ground and called 911. The paramedics also tell you that the police were the first to arrive on the scene. And they mention that they recognize the patient who has been arrested for drug possession in the past, apparently. When you examine the patient, you notice that their respiratory rate is about 8 breaths per minute, and their pupils are pinpoint and not reactive to light. So what should you do next? I know you're all thinking, administer naloxone. You are correct. As we know, naloxone is both therapeutic, it's life-saving, really, if the patient overdosed on an opioid, and it's also diagnostic. So if the patient starts breathing normally again, you know that an opioid overdose happened. So now what? I think it's important that we just spend a moment discussing implicit bias and how it may affect the care that we provide to patients with substance use disorders. I've told you that drug overdose is the #1 cause of death for an unhoused patient. I've also told you that people of color receive harsher punishment for drug and alcohol related offenses. Now what you should know is that there is data indicating that there are racial and ethnic disparities in opioid prescribing in the emergency department. So there was a study, there's multiple studies out there, but the one I'm going to reference is from 2016 that found that non-Hispanic Black patients were significantly less likely to receive an opioid prescription from the ED at discharge for visits for back pain and abdominal pain, which you should know are complaints that are often associated with drug-seeking behavior. But they were not less likely to receive a prescription for things like a toothache, fractures, or kidney stones, which are thought to be more objective pain conditions. And this was compared to non-Hispanic white patients. So fewer prescriptions for conditions that were thought to be drug-seeking, same prescriptions for things that were thought to be more objective pain conditions. So provider bias can absolutely affect how we care for someone when we're considering a drug overdose as the cause for their presentation. I want to take a moment and talk about the 2 systems of thinking. You may have heard of this before. It's the dual processes theory of thinking. Now, like it says, it's a theory, but there are functional MRI studies that do support specific regions of the brain being activated when each of these systems is in play. So our system 1 thinking, which is likely to be located in the ventromedial prefrontal cortex, which is linked to the limbic system. This is where our implicit bias comes from. Now, remember, the limbic system is where we process memories, emotions, our autonomic nervous system is in there, right? So fight or flight, system 1 thinking, from an evolutionary perspective, is our survival mode when it comes to thinking. It's very fast, it's unconscious, it's unintentional, it's uncontrollable, but this is also where our bias comes from. We don't even realize that we're doing this when we think with this system, but it's meant to be protective, again, from an evolutionary standpoint. So that's that's what happens first, right? What happens next after system 1 is system 2. This is likely to take place in the sort of larger prefrontal cortex. This is very explicit. This is controlled thinking. It is where our true reasoning comes through that we can apply to new situations, especially if we don't have, if there's like a knowledge gap that our system 1 thinking cannot fill in, because our system 1 is largely linked to experiences and heuristics. Our system 2 is where we actually have to consciously think about how to work through a situation. We take information from system 1, but then we apply logic to it and more intense analysis, and then we come up with a solution that way. So as you can see, this is very slow, but it is deliberate, it's intentional, and it's controllable. So why am I bringing this up? For me, I know that because my system 1 thinking is always on in the back of my mind, I know I have to be deliberate and intentional in engaging my system 2 thinking to make sure I provide the best possible care to my patients, because this is going to happen when you're working as a healthcare provider as well. So going back to our scenario, when I see an unresponsive patient with respiratory depression and pinpoint pupils, my system 1 thinking launches into gear, and I automatically know to give naloxone. I don't even have to consciously think about that. I just know it. I know the dose. We give it right away. And after naloxone is given and the patient stabilizes, I need to do a complete physical exam to identify other clues that may be contributing to the patient's presentation. So I'm starting to engage my system 2 thinking. I'm going to look for signs of injury. I'm going to look for surgical scars, like do they have evidence of a cardiac bypass surgery? That can affect the way that you take care of this patient. Medication patches on their skin, needle marks, whether they appear to be from IV or subcutaneous drug use, as in the case of insulin. And once I've gathered all the information I can, and I can safely leave the bedside once the patient stabilizes, to go back to the computer, because let's face it, that's where we spend all of our clinical time, is typing. I'm going to enter my orders for patient care, and then right away, I'm going to sit there and manually type out my differential diagnosis. That's what I have to do to be the most thorough, is I have to manually type it out. I can't dictate, I got to type it. And this is where I can dedicate some more time to my system 2 thinking. Even though I know at this point that the patient did suffer an opioid overdose, I'm now going to consider other reasons why a patient may present in this manner. And I'm also going to consider the secondary medical and traumatic effects that a patient may suffer as a result of the overdose. So while isolated inadvertent opioid overdose is on the differential, absolutely, I'm also going to question whether the patient used an opioid recreationally, to treat withdrawal symptoms or dope sickness, to treat pain, to attempt suicide, or whether this may have been a drug-facilitated assault. I'm also going to think about things that may complicate an opioid overdose, like pulmonary aspiration, brain injury, or other organ dysfunction due to a lack of oxygen delivery, seizures. I have to think about co-ingestions like alcohol, or in the case of prescription opioids, acetaminophen overdose. I'm also going to consider some of the longer-term complications associated with substance use. So if I'm considering, say, injection drug use, I have to think about infections and sepsis. I have to think about blood clots. I have to think about toxicity related to contaminants or other adulterants within the substance itself. So I urge all of you to think about ways in which you can engage your system 2 thinking as much as you possibly can when evaluating a patient who may be intoxicated or have overdosed, because this is an area where a bias can really derail us and potentially harm the patient. Finally, I think it would be remiss of me if I didn't also try to at least examine the intersection between substance use disorders and race. This data here is from an observational study published last year that looked at differences in the services provided to patients in the ED after an opioid overdose by race and ethnicity. The primary outcomes here were being given a take-home supply of naloxone, receiving behavioral counseling in the ED, and being referred to treatment in that outpatient setting. And what they found was that Black non-Hispanic patients were significantly less likely to receive any kind of behavioral counseling while in the ED compared to white and Latinx patients. The authors of this study posit that the difference may be rooted in provider bias, and it likely is, and perhaps also patient mistrust in the medical and mental health care systems. Fortunately, there did not appear to be any statistically significant difference in the provision of take-home naloxone or referral to outpatient treatment across racial and ethnic groups. But as you know, we as providers and as a healthcare system need to really own the fact that bias has the capacity to affect the care we provide to people of color. And we absolutely have a role to play in addressing patient mistrust. Like, this is not just a historical phenomenon, it is, but there is also a lot, like myriad modern examples of how giving patients a reason to still have mistrust in our healthcare system. Okay. So I know that's a lot. That's heavy. That actually is that's the conclusion of the presentation for tonight. I would like to dedicate the rest of our time here to any questions or discussion. Honestly, anyone, feel free to say anything. If you learned something, if something resonated with you, if you learned something new, if you have something you want to share with us, I would love to get your thoughts on what you think of the presentation, and if I can answer any questions for you. So, and I'm also not uncomfortable with silences, so I'm just going to be quiet for a few minutes, and if anyone wants to speak up, please feel free.
Great presentation, Kristin, and thank you again. You have been so great for starting this webinar, and I really thank you for all your passion and your hard work on this. We actually have a lot of new faces and a lot of medical students on the call, so I would actually like to invite everyone to take a moment and introduce themselves. Tell us where you're from and what you're looking at.
Okay, so I'll start us off. My name is Kenneth Quay. I'm a third-year medical student at the Medical College of Georgia. Dr. Peterson had plugged me into this webinar. Just trying to. I'm also 100% committed to EM. I am EM. Just topics like this really pique my interest, and I love moving forward. Will continue to coming to topics like this. Thank you.
Thank you, Kenneth. Thank you so much for coming.
My name's Kara. I'm a medical student at ATSU in Missouri, and I'm definitely interested in EM, and I love working on this type of stuff.
Hey, Kara. As you all know, Kara's like my right-hand woman in putting these talks together, so I could not do this without her. Oh, Polly, you're on mute.
Let me just add that Kara has probably increased the membership of JEDI AAEM in the last year, especially among medical students and residents from HBCUs, probably than anyone else in the organization. And I just think she's fantastic. She's a true ally and worker in this work.
100% agree.
My name's Cody Bowling. I'm a fourth year actually at AT Still with Kara as well. So I'm also born and bred to do EM. So this has been very, I've really enjoyed your presentation. One, I really love to say I like the name of this whole program, JEDI. I'm kind of a Star Wars fan, so it kind of fits. But this webinar in particular just had a good experience with a other physician who does palliative care and drug rehab, and it was a very eye-opening rotation, and a lot of the aspects you talked about in this presentation she actually went over as well. So it was just good refresher for me as someone who's soon to be making my way into residency and doing my own thing. So thank you again.
Great. Thank you, Cody. Thanks for being here. Okay, and then Patricia, thank you so much for contributing. So she's a medical student at the Universidad Autónoma de Guadalajara of Mexico. So welcome. She's doing her third year rotations in Chicago. It's my favorite city in the United States. I went to medical school there. And yes, you are right. These type of webinars are essential, especially in the US, where we have a mix of cultures and really a lot, I think, also just to learn about each other. So thank you so much for being here, and I hope you're having a great time on your rotations. All right. All right. Does anyone have like any questions or other thoughts, any comments that they want to share? Otherwise, I'm happy to give you 15, 20 minutes of your evening back. I do want to, I'm going to just stick a thing in the chat here with the link to our AAEM JEDI website, where you can get the recording of this presentation. It's usually up within 48 hours. And that's where you can also register for any future events, whether through this webinar series or any other events through our section, is all through that website. So definitely keep that link.
Hello again.
Yes.
Oh, how you doing? So I was just curious because like when you was talking about this topic, and I'm on Heme Onc right now, peds, and like sickle cell crisis, and opioids, and so I think that just like moving forward, I don't know, is there ways to get involved in part of and just be able to I guess recommend topics, and because I do think that when it comes to sickle cell, knowing when to give pain medications and when to hold back, I think that's an interesting topic. I think I'll definitely will want to dive or hear more about.
Yeah, I'm so glad you brought that up. I dropped my email address into the chat. One thing that I was going to say at the end was that I definitely want to hear if folks have ideas about topics that we can present in future sessions. We have a list, or at least I was given a list of topics that were thought of previously, and then we have a few that have been added since then. But we totally want to hear what people who are in like the learning environment or the training environment, like what you're seeing, and especially if you're finding that there is an equity issue, whether it's with students, healthcare workers, or patients or their families. Like, I think that's definitely like a meaningful place to come from when we try to develop the topics for these talks. So please feel free to send anything my way. I think that talking about sickle cell disease as a standalone topic is actually a really great idea, because I mean, I know from my personal experience, like, going to medical school in Chicago, I saw lots of patients with sickle cell disease and crises. And, I also witnessed some of the stereotyping and the sort of poor treatment that they received because they were, there's the likelihood that they would be perceived as sort of drug seeking and having other motivations for coming to the hospital for pain. And so, but, now where I work in my community, really don't see, like, I think I saw one sickle cell patient in the last like 5 years. Like it's really not that common anymore. But I think it's important, especially for those of us who are not necessarily taking care of sickle cell patients regularly, to think about this, because it's also an issue of chronic pain, and oftentimes we think of it in the subjective, where even though we have a lot of tools to be able to actually diagnose a sickle cell crisis very objectively. So I think that's a great idea. I'm going to put that on our list of topics, but anyone feel free to send me an email if you have others that you come up with.
Kenneth, why don't you email Kristin, because I think it would be great for you to get involved in helping with putting together that talk and adding it to the list and seeing, if you have a list, Kenneth is very motivated to help out with the webinar and the social media presence and advertising of the webinar as well. I know that Italo was looking for more social media push for the webinar and other things in JEDI. So we can maybe introduce him to Italo and LA Alvarez and see if they can put him to work doing some things. He's highly motivated.
That would be amazing. I mean, yeah, Kenneth, you are welcome to get involved in whatever capacity you want and are able. But yeah, definitely feel free to email me, and I can send you the spreadsheet that we have all of our topics and just like a brain dump of ideas and that type of thing. So.
And then Kara, could you also connect with Kenneth as well? Because I know you're working with Alyssa Ely, and she's come up to some roadblocks reaching and getting through to the HBCUs. And you've probably been the most successful as anyone in the last year. And maybe Kenneth can help you guys out with your connections, and you can put him to work with you guys as well.
Yeah, definitely. I got a few emails that I got through to some of the schools, but I'm not sure how much like actual signing up we got. I was going to touch base with Kathy and see if we got any more numbers from that. I'll put my email in the chat too.
Paul, you're muted again.
I think it'd be great if we could get Kenneth connected and put him to work because he's motivated. And I know Alyssa could use him, and you could too, Kara, to put him on assignment to see if he can reach out. I can connect him to Joanne Williams in Southern California because she's working on Drew.
Great. All right. Anything else? Well, it has been a pleasure speaking with all of you on this topic. This officially concludes tonight's program, but please be sure to join us for our next mentorship session that's taking place on August 29th, same time, same place. This is going to be for a discussion of transgender health with Dr. Alyssa Ely, who's one of our very active section members as well. Great speaker. We're also putting together a panel of speakers for a session on September 15th that will be dedicated to job searching for senior residents. So definitely don't miss out on that one, especially if you are a rising or current senior. You can register for all of our mentorship webinars and other section events on our AAEM JEDI website. I have that link in the chat, so keep that handy. Thank you so much again for coming, and I wish you all a wonderful evening.
Thank you.
Thank you so
Thank you
much.
again.